la bienvenida al primer evento latinoamericano organizado por Terapia de Esquemas Argentina-Americana. Soy la doctora Patricia Fernández Escudero Rothman, directora de Terapia de Esquemas Argentina-Americana, programa oficial de terapia de esquemas, avalado por la Sociedad Internacional de Terapia de Esquemas. Tengo el inmenso honor de tener como primera invitada a la doctora Joan Farrell, una de las expertas más prestigiosas y queridas de la Sociedad Internacional. Pero antes de compartir con ustedes un resumen de la extensa trayectoria científica de nuestra invitada, quisiera contarles brevemente a los que no conocen terapia de esquemas que este es un modelo integrativo avalado por rigurosa evidencia científica. Es un modelo muy difundido y utilizado en muchos países del mundo, sobre todo en Europa y en Estados Unidos, pero lamentablemente muy poco conocido en Latinoamérica. Muchos estudios aleatorizados y controlados muestran la efectividad de terapia de esquemas con pacientes con trastornos de personalidad y patologías crónicas refractarias a otras psicoterapias. Algunos de ustedes saben que viví 23 años en Estados Unidos y tuve la posibilidad de entrenarme en distintos modelos psicoterapéuticos con muchos de sus creadores, entre ellos DBT con Marshall Linehan, Mindfulness con Stephen Hayes, TCC con los doctores Barlow y Borkovec, entre otros, terapia focalizada en la compasión con Dennis Church, representante de Paul Gilbert en New York, y terapia focalizada en emociones con Sue Johnson. Pero el entrenamiento que más disfruté y en el que más aprendí a ayudar a mis pacientes fue el entrenamiento de terapia de esquemas. Tuve el privilegio de entrenarme con el doctor Jeffrey Young, creador de terapia de esquemas, Wendy Behari, nuestra experta en narcisismo y próxima invitada, y por supuesto con la doctora Joan Farrell, nuestra invitada de hoy, una invitada de lujo, realmente. Volviendo a Latinoamérica, lamentablemente somos pocos los entrenadores oficiales de terapia de esquemas, y también son pocos los colegas que enseñan terapia de esquemas en sus clases de grado y de posgrado. Por lo tanto, quisiera mencionar algunos de los colegas latinoamericanos que están ofreciendo entrenamiento de buen nivel profesional. Me refiero, por supuesto, a la doctora Samantha Flores de México, a la doctora Mayra Tiscornia de Uruguay, al doctor Rodríguez Vilches, nuestro flamante supervisor y entrenador, a quien tuve el placer de entrenar y supervisar y ayudar a certificar a nivel avanzado. El doctor Ricardo Weiner de Brasil y por supuesto la doctora Lidia Tineo de Argentina, quien ya hoy no está con nosotros. También me gustaría mencionar a colegas que desde hace años vienen enseñando una introducción a la terapia de esquemas en sus clases. Me refiero a los doctores Eduardo Keegan de Argentina y a las doctoras Margarita Dubourdieu y María Esther Lagos de Uruguay. Mi especial agradecimiento a Margarita y a María Esther por haber sido las primeras colegas que me invitaron a dar trainings de terapia de esquemas en Latinoamérica. También me gustaría agradecer a los siguientes colegas que me invitaron a dar presentaciones sobre el modelo en congresos y jornadas. Me refiero a los doctores Andrés Fleischmann, Marcela Fernández, Sergio Grossman, Annie Bernet y Enrique Stein, de la Asociación Argentina de Psiquiatría, APSA, institución de la que soy miembro. Quisiera agradecer también a todos los colegas que están realizando o han completado los trainings desde que volví a vivir en Argentina hace ya 5 años. Sus preguntas y sus comentarios me motivan a seguir aprendiendo, no solamente terapia de esquemas, sino también otros modelos psicoterapéuticos, como por ejemplo MDR. Agradezco a Rubén Lescano, al doctor Rubén Lescano, por su excelente entrenamiento. Un especial agradecimiento a mis colaboradores, la doctora Liliana Casuso de Perú y al licenciado González Martínez de Uruguay, ambos excelentes psicólogos que están a punto de recibir la certificación internacional a nivel avanzado. Felicitaciones a ambos. Pero sobre todo quiero agradecerles a todos los presentes, pues sé que han tenido que cambiar pacientes o reuniones para asistir a esta actividad. Más de 200 colegas se han registrado, lo cual me da esperanza que Terapia de Esquemas pueda ser más conocida y valorada en los próximos tiempos en Latinoamérica. Algunos colegas me preguntaron cómo son las clases de los trainings oficiales. Nosotros enfatizamos en la enseñanza práctica de estrategias clínicas, basadas siempre en conceptualizaciones detalladas de nuestros pacientes. Es importante recordar que terapia de esquemas no es un modelo ecléctico, sino que es un modelo integrativo. Debido a la pandemia, los trainings oficiales son realizados en modalidad online, utilizando salitas de Zoom para hacer roleplays. Aprender a entrar y salir junto a mis colaboradores de las múltiples salitas de Zoom me ha hecho rejuvenecer y convertirme prácticamente en una centennial. Quisiera clarificar brevemente las distintas etapas del proceso de entrenamiento de terapia de esquemas. El haber completado el training de 40 horas no es sinónimo de estar certificado en terapia de esquemas. Este training es un excelente pantallazo de todo el modelo y la base necesaria para poder realizar las supervisiones que llevan a la certificación internacional. Algunos colegas no están interesados en obtener la certificación, pero el doctor Jeffrey Young, creador de terapia de esquemas, recomienda hacer las supervisiones individuales o grupales para poder aplicar el modelo con más efectividad y lograr mejores resultados clínicos. Ahora sí, quiero hablarles y presentarles a nuestra invitada de hoy, la doctora Joan Farrell. Joan no es solamente una excelente investigadora, supervisora y entrenadora, sino que es también una gran persona que representa muy bien el espíritu de terapia de esquemas. Joan es la presidente del Consejo Asesor de Certificación y Capacitación de la Sociedad Internacional de Terapia de Esquemas. Es la codirectora del Instituto de Terapia de Esquemas del Midwest, profesora de Psicología Clínica de la Universidad de Purdue y supervisora de su departamento de posgrado. Es coinvestigadora junto con el Dr. Arnold Arntz de los estudios que demostraron la efectividad de terapia de esquemas con pacientes borderline. Es autora de numerosos papers, capítulos de libros y ha escrito 3 libros: Schema Therapy, A Clinician's Guide, Experiencing Schema Therapy from the Inside Out, y su libro, este sí, traducido al español, llamado Terapia de Grupo centrada en esquemas, del trastorno, por supuesto, límite de personalidad.
Thank you very much for that lovely introduction. And I just have one question. I'm very glad to be here, and I'm very impressed at the number of people who are here with interest in schema therapy and treating borderline personality disorder. My one question is, do I still have an hour for the presentation? I'm trying to manage my time. Okay, good. All right. So I'm going to talk about overcoming the challenges of borderline personality disorder with schema therapy interventions. And I began my specialization with this group of patients in the late 1980s, when a lot of us thought, not me really, that people with BPD were not treatable. And really, schema therapy, originally with Jeffrey Young, was developed to fill the gap that CBT left in treating personality disorder patients. And some of the challenges to cognitive therapy that this group of patients presents is that their cognitions and behaviors are more rigid. The gap between cognitive and emotional learning change is much greater. Interpersonal relationships are more central to their problems. They often don't do homework, and this is very relevant for BPD. So in 1985, we had this idea that we should change treatment to meet the needs of borderline patients. And so we identified 3 problems. They couldn't stay in sessions because they were too distressed. They had emotional regulation deficits. Their global level of emotional awareness caused them not to realize their distress until they were in very intense distress. And so there were gaps in emotional learning. Experiential interventions were needed. And their maladaptive schemas kept them from taking healthy action. When we started working with these patients and also in groups, like Marsha Linehan, we thought that they had deficits in skills. But what we soon discovered was we could teach them skills, they could use them in the sessions, but they didn't use them outside of sessions. And when we asked them about this, they basically said, well, we're bad and we deserve punishment. We're not going to do these things for ourselves. That's when we realized the critical role of early maladaptive schemas. We went on to develop a number of programs through the Indiana University School of Medicine and a Center for BPD Treatment and Research. Some of the studies that you'll read about on schema therapy for BPD came out of this institute, including the 495 patient study that was done in 5 countries that we've just finished and are submitting for publication. We still have an outpatient clinic, a schema therapy program here in Indianapolis that has 200 borderline patients and a very brave psychiatrist who I trained. Group schema therapy that Ida Shaw and I developed uses the theoretical model of schema therapy, and the course goals and treatment components are consistent. What you see here, our first book, Group Schema Therapy, served as the protocol for the recent study, and it was expanded in the Schema Therapy Clinician's Guide, where we also include a protocol for individual schema therapy. We did make a DVD as well of us doing group schema therapy with 8 schema therapists who were playing our borderline patients. They played so well that when people see this DVD, they sometimes think that they are actual borderline patients. So to look briefly at the schema therapy conceptualization of borderline personality disorder. We hypothesized that core childhood needs that aren't met in the childhood environment, combined with a temperament that's highly emotional or labile, lead to the development of early maladaptive schemas. And when these schemas are activated, modes are triggered. Mode refers to the present state a person is in. And this may be the innate child modes where strong emotion exists. They could be the maladaptive coping modes, the fight, flight, or freeze responses developed to the situation of core childhood needs not being met. And there's also the dysfunctional critic, which may be punitive or demanding. And these are mostly the thoughts people have that embody the schemas and are very negative and upsetting. And these modes can flip, and this leads to the problems we label as personality disorder. Schema therapy's etiology fits with borderline patients' experience. Their childhood environments tend to have been unsafe, emotionally depriving, harshly punitive, invalidating, and combined with biological factors, end up producing this disorder. Early maladaptive schemas in schema therapy are the pervasive themes or patterns, memories, bodily sensations, emotions, and cognitions about oneself and relationships that develop during childhood and adolescence and are elaborated through the lifetime. They're dysfunctional to a significant extent. Someone has their mic on. Okay, this definition is broader than the CBT definition of schema. I'm just going to try to mute. No, I can't do it. Okay, I was going to try to mute his mic. Again, the CBT definition focuses on the cognitive or the core belief part of schemas. And these 18 early maladaptive schemas load into 4 domains: disconnection, rejection, and that's where we have some of the prominent schemas that are troubling with BPD: mistrust and abuse, defectiveness, shame, emotional deprivation. There are also schemas in the area of exaggerated expectations, impaired limits, impaired autonomy, and performance. And of course, in the schema therapy training that Dr. Escudero-Rotman does, you would find out all about this in depth. Schemas are trait-like. They're always present, but they may be dormant. So here we have the idea that schemas are under the surface, but they are activated either by external situations or by emotions and thoughts. And borderline clients have many early maladaptive schemas, and their schema activation tends to be ongoing. Modes get triggered when schemas are activated. And when modes are triggered, perception, interpretation, and mood are impacted. And here we have the situation where schemas trigger the child mode, so intense emotions, and then the critic mode, which says you're not supposed to have these strong emotions. And then the coping mode occurs, the fight, flight, or freeze. Then that's the pattern of mode activation. Schema modes, as I said, are intense states triggered when schemas are activated. And it's the predominant state we're in at a given point, including our neurobiological state. And we all have modes and we all have schemas, but the frequency and intensity of them are more severe in patients with personality disorders. Another way to look at this is that they're parts of the self that haven't been completely integrated. And that refers to kind of a spectrum of dissociation. Jung developed the mode concept to explain the behavior of clients with personality disorders. And again, there's a continuum of functioning. With higher functioning people, there's more awareness of the modes, and the modes are sometimes maladaptive. They don't as completely determine the person's behavior. And with lower functioning patients, the mode takes over. They tend to be maladaptive and rigid. And rather than existing like moods, they're more dissociated parts of self. There are 4 types of modes in this model. The child modes, which are innate responses to unmet needs. A child's hungry or hurt or wet, uncomfortable, it screams, it responds. In a sense, these child modes go back to that innate response to needs not being met. And it's intense emotions that the child modes primarily consist of. Then there are the dysfunctional critic modes, sometimes referred to as parent modes. And this is the selective negative internalization of early caregivers, adolescent bullies, etc. And the critic comes in the form primarily of thoughts. Then there are the maladaptive coping modes. These are overused survival responses to trauma or unmet core needs. And there we have the behavior. And there are healthy modes. These tend to be underdeveloped in personality disorder patients. Oops. And again, borderline patients have many schemas and mode triggering is frequent. The child modes are frequently triggered. And I'm going to look at a case that will maybe flesh this out for you. The maladaptive coping modes are also quite often, like what we call detached protector, that may be as severe as dissociation, to block the painful emotions of the child modes. And the dysfunctional critic mode often follows and criticizes the person for the feeling, for the behavior. And mode flipping results in instability in borderline patients, even in instability in terms of identity. Mode reactions are too big for the current situation, and they're not effective to meet the underlying need. A good example of a borderline angry child mode would be making a request, the request isn't granted, and what you see before you looks like a child having a tantrum. There are a variety of child modes that are identified in schema therapy, and they're related to the underlying schema that's involved. So you may have a child mode where the main experience is that of abandonment and the terror and fear of an abandoned child. It might be an abused child or a lonely child or a dependent child. But again, these various child modes, it's important to be able to identify the mode your client is in, because what he or she needs from you depends on the mode that's present. The coping modes are also divided into a number of categories. There are 3 main styles that correspond to fight, flight, or freeze, but then within those styles, there are a number of different varieties. For example, with the avoidant mode, flight, you have a detached protector that's like psychological avoidance. The person's body's there, but emotionally and mentally, they're not present. You have the self-soother, someone who might use drugs or alcohol to soothe the strong emotions of their child mode. Could be an avoidant protector, the person who doesn't show up, who stays at home and is physically avoidant. When it comes to overcompensation or acting the opposite, really, of what the feelings in the schema is, we have modes like the self-aggrandizer that we see in narcissistic clients, and that is a way to cope with their underlying feelings, for example, of defectiveness. We also have the demanding critic or the punitive or guilt-inducing critic. The demanding critic is the one who's always wants more. Nothing's ever good enough. And they may not include punishment. The focus is on the demand. Or the punitive critic, often the kind of caregiver that borderline patients have, who really feel that it's reflected in that message I told you our borderline patients gave us, the feeling that they're bad and deserve punishment. That is the result of a punitive critic. So in a person with borderline personality disorder, we have the vulnerable child mode, the angry and impulsive child mode, and then coping modes to deal with all of that intense emotion, often detached protector, detached self-soother, sometimes the bully attack mode, and a very punitive critic. Schema modes explain the intensity of borderline patients. Schema modes can erupt when an everyday event hooks a schema issue in some way. Intense feelings are triggered, negative coping modes occur, and the patients may flip from mode to mode in response to external and internal stimuli. And extreme mode experiences may not be remembered, but the reaction is too big for the immediate situation. It's hooked some of the unprocessed emotion from the past, from childhood experiences. And the modes are very good in explaining, even in DSM-5, the borderline traits that are seen. The emotional lability we see in borderline patients can be the result of mode flipping. Their separation insecurity and anxiousness, the vulnerable child mode. Their depressivity, the punitive critic. Their hostility, the angry child mode, the bully attack mode, the angry protector, and their risk-taking and impulsivity may be seen in the impulsive child mode. I think it's important that the mode model can account for the clinical presentation and symptoms of BPD, and it does it in user-friendly language that our patients can understand. So if we look at the main categories of modes, by color here, I'm matching them up with these symptoms or experiences that are part of the disorder. And self-injury and suicidality are more complicated. They may be related to the punitive or demanding critic. They may be related to the vulnerable child. It's people self-injure for a number of different reasons and with a number of different underlying needs. Their depressivity is often the result of detachment and surrender modes. But mode flipping explains the more severe symptoms, the emotional lability, the unstable self, the unstable relationships, and even the disturbed reality connection that can occur in brief psychotic episodes. So rather than working by symptom, in schema therapy, the modes provide us with the foci to follow in treatment, and they explain the presentation. They also explain the presentation to your client, who may have felt very crazy, would be the word that I would hear all the time. And it's often the word that borderline patients get described with non-clinically. And I think it's the mode flipping that can explain that amount of chaos. So what are the treatment challenges of BPD? They're insecure attachment. They have a very frightened, abused, vulnerable child. Their low levels of emotional awareness. Their entrenched maladaptive coping modes, for example, detachment, dissociation, self-injury, suicide attempts. They're strong, punitive, demanding critics. A vulnerable child who's frightened, sad, and lonely. An angry child who doesn't trust. And very little healthy adult. The schema mode inventory is a questionnaire that measures the presence of modes in people. And when you look at the profile of a borderline patient, you do end up with a strong, vulnerable child of some type, a number of different coping modes, a very strong, punitive, and sometimes also demanding critic, but very little healthy adult. So the goal of schema therapy for any client is to help them get their core needs met in an adaptive manner through changing maladaptive schemas, coping styles, and modes. And the way we go about this, the goals we have for these different modes, we're trying to get around the coping modes to reach and heal the vulnerable child mode. We want to diminish the power of the critic mode. We want to channel the angry child mode into assertiveness, set limits, healthy limits for the impulsive child, evoke and develop the happy child, and develop the healthy adult mode to be able to perform these functions. So our ultimate goal is autonomy. Oops. Schema therapy treatment, like other treatments, has stages. The first stage is bonding and emotional regulation. The therapist approach in schema therapy is referred to as limited reparenting. And that means acting as a good parent would to try to provide validation, acceptance, safety, and connection. It's not just a therapist style, it's also one of the main interventions of schema therapy. It means really providing corrective emotional experiences to fill the gaps in their early emotional learning. In this first stage, we may be dealing with handling crises, affect regulation, coping skills, kind of emergency measures if there are life-threatening behaviors involved, setting limits. And then we have schema mode change. As I described, by the mode, there's a different change that's focused on. And ultimately, autonomy, developing healthy relationships, learning to follow their natural inclinations, and a gradual termination of therapy with the option of future contact. It's kind of like a parent with an adult. You know, you go off, but at times of need, you may come back to work a little more on something and then go off again into your life. Just to mention the main interventions of schema therapy, the therapy relationship is crucial. A focus on attunement, validation, corrective emotional experiences, guidance, sometimes outside of session contact, going a bit above and beyond what a warm, helpful therapist would do. Education. In summary, it's being a good parent within the bounds of a professional relationship. We also use the whole range of cognitive interventions, schema diaries, mode awareness diaries. We identify cognitive distortions, pro and con lists, work on reattribution, trauma processing. Then there are emotion-focused interventions, imagery, work, like the safe place image, imagery rescripting, mode dialogues, mode management plans, labeling and awareness of emotional state, transitional objects, and behavioral pattern breaking. Behavioral experiments, therapy assignments in imagery, breaking schema-driven behavior, flashcards, skill acquisition, for example, assertiveness, etc. Often with patients we treated, they had been considered failures in other treatments like CBT or DBT because they didn't use the skills they were taught, and they couldn't come up to the level of healthy adult that those treatments required. But once we kind of got around some of the disabling schemas and disruptive modes, then they were able to use these skills to good effect and integrate them as part of their healthy adult. The philosophy of schema therapy treatment, particularly with BPD, is that we view patients as a vulnerable child, that they're genuinely needy, not greedy, but that the therapist has rights too. We don't just put up with a lot of negative behavior. For example, in the bully attack mode, where the patient may be calling you names and telling you what a terrible therapist you are, we would stop it and limit it, because what they need is a healthy limit. They didn't learn healthy limits in their childhood. But we don't blame them when we're frustrated. This work can be quite slow. The inpatient program that we had here was in a hospital connected with a medical school, And we were sent patients that no one knew what to do with from around the state and even from around larger areas. There are about 6 million people living in Indiana. So we ended up getting the most challenging of those 6 million. If you say that you like to work with people with BPD, you don't have any shortage of patients because not everyone wants to work with this group of patients. That's probably why we still have 200 of them in our outpatient clinic. The stages of treatment really parallel child development, and it's very important to convey mutual respect and genuineness. There are advantages of the mode approach for BPD. When we educate patients about modes, they can come to more fully understand why they react so differently across a broad range of life situations. It gives therapists a way to track and understand the here and now mode shifts in affect, cognition, and behavior that can take place during a session. And we can develop specific treatment strategies for each dysfunctional mode. And validation, connection, and providing safety allow them to engage in the treatment. We need an active collaboration.